We will try and get through the business today in a timely way. So I would ask that you keep your questions to the usual 5 minutes in order that we don't make it drag on too long, if that's possible. As I'd like all members to be able to discuss and join the debate if they wish to do so. So can I accept the minutes as a true and accurate record from the last time's meeting, please? If you can remember, it seems a long time ago and lots of things have happened, but if you can remember, yeah, everybody happy with that? Okay. Apologies for absence, please.
We've just had apologies from Councillor McGrath for other reasons, with Councillor Foll substituting.
Thank you very much. Welcome, Councillor Foll. You'll soon be a permanent member on this committee. You never know. None of us ever know. Right. So, do we have declarations of interest from members, please? Pecuniary. Councillor Reddy.
My husband's a community staff nurse.
And my daughter is works at Queen's Medical. Councillor Welsh.
I always say this just to be safe rather than sorry with regards to declaring an interest, but a family member is having treatment in one of the units that is under discussion today, so I just wanted to make sure that everyone was aware of that.
Fine, thank you very much. Anyone else? No? Good. Anybody have a private interest, pecuniary or non-pecuniary? No? We're all interested. Right, okay. So, the first item on the agenda is agenda item number 4, and I would like to welcome the Nottingham and Nottinghamshire ICB representative, Lisa. And I think you're going to take us forward, and the divisional director for surgery. I'm going to let you introduce yourself, sir. And you're going to talk to us about the transfer of elective surgery.
Yes, morning everybody.
Please feel free to start. Go ahead.
Sorry. Morning everybody. My name's Lisa Durant, System Delivery Director of the ICB, and I have with me Mr. Ian Banishee, who's going to describe some of the detail of the transfer of some of the elective services from Queen's Medical Centre to City Hospital. So we're beginning this transfer with colorectal and hepatobiliary patients who can have their elective surgery at a site away from the main A&E, which provides a level of protection around cancellations, etc., and will offer some high quality elective care in a new setting over at City Hospital. We're going to Mr. Banishee is going to describe the first stage, which is the development of a ward and the subsequent development of some theatres to support that, all part of the wider Tomorrow's NUH discussion. So I'll hand over to Ian.
Thank you, Lisa. Good morning, everyone. My name's Ian. I'm a colorectal surgeon, but I'm also the divisional director for surgery. Obviously, this investment is a large investment in developing elective and cancer planned care for two very important services for our local and regional population. Part of that investment is the ward, which is built and is open. We took partial possession of that at the end of January. There were some internal snags that we needed to address with the contractors, partly because we wanted the ward to be right before we took it on, but also because there were certain areas where there were some patient safety concerns. So in the last few months, we've been running that as half a ward, 10 beds initially on the ground floor, whilst the first floor was upgraded. That's now complete, and the service has moved upstairs whilst the ground floor is corrected, and we're hoping to take full possession of that in the next few weeks. In the meantime, Council may be aware that there have been delays to the theatre construction that goes in line with this. Obviously, you need theatres and beds to match up in order to provide elective care. And the fundamental issue there was some delays around having to make some changes to infrastructure in the ground, which needed some approvals from local utility companies, and unfortunately that took a little bit longer than we were anticipating. So those have now been addressed, and we're hoping that the build will be complete at the end of June or the beginning of July, with a little bit of time then required in order to orientate and clean and be able to get the theatre suite running and the post-operative care beds that are part of that build. In the meantime, our staff have gone to great lengths, both theatre staff and surgical teams, to, if you like, rather than make what was already a big move to move part of their service around the ring road from one site to another, they've split themselves further. So the colorectal elective programme currently is running at both City and at Queen's in order to avail the facilities that were available, and that's had a positive impact. The feedback from our patients who've enjoyed the new ward facilities has been very good so far. The staff, when the ward opened, had beaming smiles on their face because it is a very modern and appropriate healthcare facility. Obviously, when you start a project like this, you wonder whether you will be able to recruit the staff that you need. And I'm pleased to report that when the ward is fully open, it will be staffed to be able to open all beds. And that's a significant achievement to my colleagues who've led on that and worked really hard to get us to a point where that's feasible. I think that's probably all I need to say, but we'll very happily take questions.
Well, thank you very much. That was. Did you want to come in?
Is that okay, Chair?
Yeah, of course it is.
Thank you. So, good morning, everybody. I'm Alex Ball. I'm Director of Communications and Engagement for the Integrated Care Board. I just want to say a few words on how we've worked with our citizens on this move, which was one of the requests from the committee last time we were here. So, the ICB has worked with colleagues at NUH using a variety of means to make sure we talked to patients undergoing hepatobiliary care. It's worth noting that in that feedback, patients are overwhelmingly positive about their care. So 70% of patients said they were very positive about the kind of care that they were receiving, which is a testament to the kind of team that IAM leads and the positive kind of nature of the way they're approaching their work. There were some concerns raised about the proposed move to the City Hospital, but overall there was a balance of respondents in favour of the move, particularly noting the easier transport access at the City Hospital site versus the Queen's site. And the majority of patients, it's not a referendum, but the majority of patients were in support of travelling to the City Hospital if services were relocated there. And we kind of set that alongside the clinical and the operational kind of case support for this move to kind of inform that overall direction of travel. There is some work we'll need to do to continue to work with the local authority and other partners to make sure that any kind of transport kind of final kind of sort of transport niggles are ironed out, but we do believe it's manageable. And there was a little bit of feedback about some of the kind of quality of the patient-facing literature and materials both before and after the surgery. So there's a small bit of work that needs to be done there. But overall, when we spoke to patients, they were content and supportive of this move, which is an important part of our consideration of these types of changes. Thank you.
Thank you, Alex. Thank you for that briefing on where you're up to. Obviously, clearly you've had a delay. My question, as always, Alex has alluded to it a little, is the parking. Because you have what you have available around the hospital, and you're bringing more people in. So my question, as always, is where are they going to park? Because if they're coming in or the visitors are coming to see them, I can see that parking can be a problem. So I would like to be reassured that that parking is really being looked into, because it's not only your department that's moving there, it's many, many departments, and therefore there are going to be many, many vehicles. So I'd be very interested in that.
Yes, so I mean, I think that is a very important point, and it certainly came up last time. A lot of changes have happened since then. Previously, when we've had issues with parking, it was in the the latter end of COVID, when barriers were up and a number of people without permits were using a number of car parks. Reinstituting the barriers and the new parking system has made a difference to that, to the best of my knowledge. There's a piece of work going on as we speak around the allocation of staff parking permits, and as you might imagine, there was some concerns from the staff as well as to how they would be able to park. And I'm not aware that anyone has had issues from a staffing point of view. The benefit of managing the staff permits a little bit better has meant that the access for patients and their visitors has also improved. And to date, I'm not aware that we've had any issues with that or any recurrences of some of the problems that we were seeing some months ago. But clearly, we need to keep an open mind on that and see where we get to. But it will always form part of our overarching parking strategy.
Okay, thank you. Councillor Wilmot.
Thank you, Chair. And thank you for the report. It's a very thorough report. It is a little disappointing that there's some delay in the progress of delivering the transfer of the elective services at Nottingham University Hospitals. In fact, the current report is saying that there's a delay in delivering the location, including the business case as yet to be agreed, that mobilising the contractors was proving difficult, and that there is underground work to be done before the project can start, and also that there were some legal complications. I was wondering why this work was not investigated before you actually got to this point. You know, it's normal. You investigate all the areas that you should do before the actual project starts. And can I say, will there be any additional consultation taking place? Because as we all know, the people that took part in the process were very few and far between, and there's still concerns that some of the services will remain at the Queen's Medical Centre. How will you respond to that concerns? And also, can I say that
Not too many questions, Councillor
Yeah.
Wilmot. The guests have got to remember what you're saying, so
and
just
the final
give
one,
everybody else a chance.
the final one is as I say, the addition with the additional legal fees, the additional infrastructure work. Will the project still be able to be delivered at the budget that you've set? Thank you.
He's got to stop. He's got to think of his own. Right. Are you going to answer?
I'm going to start, and I'm going to try and remember all of your questions. So do forgive me for having it, and then I'm going to maybe hand over to Ian and Alex to fill in some details. In regard to the way that you do business cases and the way that you would develop it, of course, there is always a need to make sure that you've secured the capital. We are in the process of the future sort of capital developments and working with NHS England, and we've got no reason to think that this won't be successful. The legal issues and the logistical issues, I'm going to let Ian talk about the logistical issues specifically in regard to sort of what the delays were. But I think your broader question was also, are we confident that we can continue with the bigger project? And I think the answer to that would be yes. And I'm going to let Alex perhaps comment on the way that we'd agreed our approach to engagement with the public and future consultation. So hopefully I've captured some of it, and then I want to ask Ian to comment on the specifics of why those delays happened.
Thank you, Lisa. So there was survey work done and preparation work done in anticipation of the project, but there are always, as with many building projects, things that emerge as the build proceeds. I'm not aware of anything to suggest that the build won't complete. In fact, we're very near to the end, and some of the issues that you're asking about have been looked at and addressed. I think there is always the sense of planning for the future and then having to accommodate your plans depending on what else happens within your estate. And I think some of what you're referring to in the paper is the fact that one of the challenges is around some of the existing theatres that we were hoping to ease the transition with no longer being available to us because of those other theatres not being as usable as we'd originally planned. But as I said earlier, the essence of this project is due to be completed later on this summer.
We just come back with one. You did say that you haven't got yet established all the funding that it is needed. I don't get that at all.
Shall I answer?
Yes, please do.
The funding for this part of the build is secured. For future bits of the build, so as we develop our elective services at City Hospital, as we've said, in line with tomorrow's NUH, we're needing to work with NHS England to make sure that they're comfortable also with the business cases that have been proposed for various stages of building. So this is one phase of it, but the funding for this phase is secured, and as Ian said, we have no reason to believe that that will be a problem. For the future, we have to be as robust as we have been, and we have to make sure that we have the all of the elements that you would expect in place for any big build.
Thank you. Sarah, did I see your hand go up? I thought I did.
Alex wants to make another.
Oh, well, sorry, just 1 minute, Sarah. I think Alex wants to come back.
Thank you, Chair. Just to pick up on Councillor Wilmot's question around, how broadly we've involved our public on this. I think it's a really helpful observation. And you're right. We would have liked, I think, to have spoken with more patients, more members of the public on this particular topic. The exact timing when we did this, just before Christmas, it was an exceptionally busy time for the trust, so that did hamper us ever so slightly. What I will just say is, as Lisa's already mentioned, the overall sort of direction of travel of our intention to move elective surgery to a single hub on the City Hospital campus, of which this is a part, has already been quite extensively sort of explored and engaged with the public. So as part of our engagement around tomorrow's NUH, last spring we spoke to around 2,000 individuals about all of those proposals, part of which includes the proposal to consolidate elective operations in one place away from urgent and emergency care. And 80% of people said that they were supportive of that. So that gives us a sense kind of from an overall landscape that broadly our direction of travel here is supported by our public. The work we did on this specific change means that we can be content that the quality of service is doing what it needs to do, and we're getting a good response on that. But yes, we would have liked to have heard from probably a few more people on this. The final bit I'll just say is, as part of those overall proposals for tomorrow's NUH, our intention is later this calendar year to be out to full public consultation on that, assuming we get agreement from NHS England and some other bodies to do that. So that will be a further opportunity for people to input and comment on this move in particular and that overall kind of direction of travel. So I hope that's helpful.
Thank you, Alex. Sorry, Sarah, back to you.
So Alex has addressed some of the concerns, well, not sure addressed, but mentioned some of them. So obviously in July last year, this committee asked for a more in-depth targeted engagement on this particular issue. And looking at the numbers of 22 surveys completed, that's only 1.5% of the total elective patients that come through that service in a year. So I think obviously saying it was before Christmas when we asked you in July last year to do more targeted work. I still think there's a lot more work can be done on engagement, particularly around this. And obviously I take the points about tomorrow's NUH and the engagement done on that, but by its nature it has to be very generic within tomorrow's NUH consultation, whereas this was very specific to this particular service with these particular patients. So in that sense, I do feel that we need to look at how you'll improve the way that engagement is done particularly on something that affects a specific group of patients on a specific build, and only 22 people responded to a survey. So, that's just my point from a Health Watch perspective, and our job is there to look at how the ICB engages with patients and looks at that agenda. So that's my point, and I appreciate Alex giving the background in terms of 2,000 people responding to tomorrow's NUH consultation, but I still think that 1.5% of the total number of patients, 22 surveys, is very underrepresentative of the views of that particular patient group.
Thank you. Would you like to comment on that?
Yes, certainly. If I can take that one, so I absolutely accept that, and that needs to be an ongoing process, which we accept. I would say that the feedback that we're getting, because obviously each week we take feedback from our patients, is overwhelmingly positive. And I think there are elements of detail that aren't always necessarily known by our public. So even before this more formal move happened, because of constraints around resources, the colorectal service were, prior to the pandemic, undertaking robotic surgery at City Campus. In many ways, that was what led us to consider the feasibility of moving. And similarly, during the pandemic, obviously, we found ourselves delivering elective care at independent sector providers. And so our colleagues in colorectal and in HPV both did that, and we often found ourselves having those conversations with our patients around the implications of having their surgery somewhere else, and both in terms of getting there, their families getting there, and the post-operative care. So some of that is recognised and has been thought about, even if it hasn't been part of a formal consultation, if that makes sense. It's something that we need to carry on addressing. The feeling, if you like, from the clinical teams is that being able to look after those patients in an area where they're not competing for interest with emergency patients who are sicker is overwhelmingly better for them and reduces their time in hospital and improves their care. The colorectal team have done a piece of work around what's called enhanced recovery after surgery, and some of the communication materials that were mentioned earlier in terms of preoperative counselling, and were winners of a national award for their work on that. So recognise that the consultation as presented is limited, but would suggest that there's a whole piece of work going on in the background that feeds into the decision making.
Do you want to come back, Sarah?
Yeah, just briefly. I appreciate that, and I think obviously, clinical opinion is really important in terms of how the recovery of patients is done. Also, I know there's a lot around that. I still think, though, with tomorrow's NUH, when we're talking about putting patients at the heart, that having clinical discussions that are pretty much the majority of the decision making, with 22 people from the public feeding into that, doesn't really say that you are putting patients themselves and their opinions at the heart of your decision making. So I absolutely understand, and I don't have an opinion on whether this was a great or a difficult decision to make. I think feedback, obviously, the ongoing feedback will tell just how successful it is, and I'm sure it will be. I know in terms of how services can be brought together, it's a really good thing. I'm just making that point about the engagement and the importance that we should be putting on patient voice alongside clinical experience and voice, and this feels very disproportionate.
If I could just add that again, I accept that, and just as one other point, there is a patient representative on our committee or steering group for all of this. Clearly, one individual can't represent all of those patients. Again, accepted, but we're trying to bring in the patient voice as much as we can, and we will do more work on that area.
Thank you. Just before I move on, picking up what Sarah said, 22 surveys seems ridiculously small for such a large movement. Do you feel yourselves that you did sufficient advertising? It says you had posters in the outpatients department, and I'm sure people sat there and looked at it. But were people moving around? Did you have anybody who could help people, tell them where the forms were to fill in, or did you just leave it if you want to do a survey, just answer the survey? Because this really, in my opinion, isn't a survey of 22 people. Do you think you could have bettered it in any way?
So I'm happy to say, so it's self-evident we could have and should have want to have a wider amount of responses there. So yes, we did do quite extensive work, exactly as you've described, kind of people with clipboards, kind of prompting it. I guess the colleagues may have been in for kind of surgery. You know, you're in quite a mode of mind, aren't you? And it's quite hard, I think, for us to potentially expect people to reflect on that and kind of respond to a survey when they're probably thinking, am I going to be seen today? Is it going to go all right? So I think that's definitely a learning, and I'm grateful for Sarah's kind of feedback and reflections that I think for future sort of targeted moves like this, we need to think again about our approaches and kind of redouble our efforts.
Perhaps when they've had the surgery.
Yeah, I think
and they're not quite so stressed when they know it's all gone right.
Yeah, again,
rather than when they're waiting for the surgery.
There's a sweet spot, isn't there?
And
there's a
imagining all kinds of things that could happen. Yeah. Okay. Thank you for that, Councillor Foe.
Yeah, thank you. Just to show how seriously we take consultation. My question was going to be about the consultation too. I mean, to be honest with you, 22 responses isn't just disappointing. It's statistically irrelevant. It really is. You cannot base decisions or bring a report like this to hear it and use that as evidence that it's working. And do you know what? I think it's a brilliant initiative. It really is, and it's great to see it. But I just have a suggestion, which I hope perhaps taken in the spirit if it's meant. And again, Alex, you were talking about what kind of one person kind of being on the board. Again, this is nowhere near getting the patients at the centre of any kind of decision making. Nowhere near. And I just wonder if it might be helpful if the ICB could come up with a report to this committee that demonstrates how serious they are about consultation and how they're planning to do it in the future. Yeah, because because this doesn't suggest that that's the case at the moment, and I know how hard it is. I mean, we've done it here at the county; it's really difficult just doing it online, and the responses here weren't terribly good. So I think we've got to be creative, but I think we need to understand and appreciate how serious you are at actually kind of getting the patient voice in, and that is just a suggestion. The only other thing I was going to ask, which is a completely different subject, which may be some relief to you. I just wonder, because this clearly is brilliant stuff, because there's an awful lot of people waiting, isn't there, for as we know, there's a really big waiting list. What about after this has been done? Do you have the capacity to do the aftercare after they've kind of been in this unit and have the treatment? I'm sure will be very good. There's not going to be another bottleneck there that's actually going to significantly impact on the future health of the people who've had this service.
Can I just clarify the question? You mean in terms of post-operative follow-up? Yes. No, I think that's a really important point, and I think just to pick up on the question around consultation, I think really now that we've made the move and accepting that the patient consultation element could have been much wider and much more in depth. If I were to be asked who we should ask about the consequences of this move, I would probably focus on patients who've been treated at both sites. Because it's only when you have a comparator of having been treated in one site and another that they'll be able to tell us whether one is good or better than the other one. And of course, any pre-project appraisal would always have been constrained by the fact that the people we were asking would only be able to comment on what elective surgery at Queen's is like, without any necessary real experience of what it might be like at a cold site. In terms of the post-operative follow-up of these patients, that will be accommodated. Both teams are obviously very dominated by cancer surgery and have clear-cut surveillance programs that don't necessarily rely on attending clinic all of the time. Indeed, the key to good cancer survivorship is to make sure that patients get their scans and other tests in a timely way, and relying on a clinic-based system is often flawed in that setting. So the colorectal service have that set up already. The liver service have a similar process that could evolve a little more. There are, of course, lots of other important non-cancer patients that will need to come to clinic, and those are areas that we need to balance and make sure that we're seeing the right patients in the right place. But I think one of the issues that was raised earlier was the fact that these services are separate and may not be at the same site. That has been true for many of our patients for a long time because of the splits with oncology, which is mainly centred at City campus. And it's never really raised an issue when we spoke to our patients about the fact that they're going from one site for elective surgery into another site for their oncology aftercare. The key is to guide the patient through that journey with good support, and both the surgical teams and the oncology teams have nurse specialists and other members of teams who provide that contact and that ongoing care. And we'd like to develop that even more so that it's individualised and almost takes a patient navigator type approach through the entirety of the pathway.
Thank you. Councillor Welsh.
Hi. So firstly, I just want to agree with what Councillor Fowler's just said with regards to the consultation. But just moving away from that now, because I think everyone's spoken about it. Not that it's not important, but I've just got a couple of other questions. Within the report, it talks about the national context and the local context, both of which really concern me. And the reason that they concern me is with regards to waiting lists and how long it is taking people to actually get this elective surgery, and the hospital's capacity to deal with actually the amount of people that need this, because the need is growing and it must feel like you're chasing your tail quite a lot. So my question is, first of all, I agree with the move. I think that to release the capacity at the Queen's Medical Centre is very, very important. You go into A&E and you go around QMC and you see actually how full it is. You only have to walk around there to see there is a need to move some of that capacity. And I really like the City Hospital as well. So just to say that as far as moving it and increasing the capacity, I totally agree with that. My question though is, how much capacity is this going to create in real terms, in the sense that next year, if you were to come to us, how much of an impact is it, in reality, is it going to have on those waiting lists? How much of an impact is it going to have with regards to people receiving what they need to within a timely fashion in line with medical pathways? Because that's not currently happening for everybody. So people aren't getting what they should within the time frames with what is medically advised to be. So my question, it's not a trick question, it's not to catch everyone off guard. My question is, I agree with increasing the capacity. I agree completely with what you're doing. I think it's really vital that we do it. It's a massively important piece of work. But my question is, in reality, how many people are still going to be sent to Woodthorpe Hospital, for example, private hospital, which must be costing the trust an absolute fortune, or to the other private hospitals, because you just don't have the capacity within the trust at the moment to do it. And that is there, and it's big, because I've sat in the waiting room and I've seen how many people are going in to see that consultant at Woodthorpe Hospital. It's not a small number. So if I was to go in that waiting room in a year's time, will it be less or greater? The question you won't be asked is how many patients come through your door. I know you won't, because more might, but is it in reality going to make that difference? I hope I'm making sense about babbling, but is it going to make a big enough difference to make your job easier and to give the level of care that I know that you want to give?
Mayor, yeah. So that's a really good question, and you're absolutely right to ask that question. And this is, if you like, a key part of our strategy, but it's not a single magic wand that is going to make everything disappear. We need to understand, to a certain extent, how the elective backlogs have grown over time. Clearly, the impact of the pandemic was a key player in restricting what we could do in terms of doing it safely and our thinking around that. But it also had an impact on our people. And one of the key issues that arose even after or in between waves of the pandemic, if you like, was that there were theatre staff and or anaesthetic staff predominantly who weren't working for us anymore. And so alongside the big capital developments like wards and theatres, there's a really important question around recruitment and retention. And the two are often interlinked. As I said earlier, the ward is due to open with a full team. That in itself is an achievement. Our lead for the theatres that are going to open, who's had a very difficult job of moving a team around the ring road, has also gotten to the point where her theatres will be fully staffed. So that's a significant improvement there, and then there are knock-on benefits in what you leave behind, because obviously by moving these services, we're leaving theatres at Queen's, where if we can recruit staff and anaesthetists, we will be able to do more elective surgery, perhaps even non-elective surgery, if that's strategically the right thing to do. But that takes time to recruit and bring those teams together. I think earlier on, when Councillor Wilmot was asking his question, that's, if you like, the next knock-on steps of this strategy. And there are further plans, both in terms of developing the elective hub at City and also improving patient flow at Queen's, because not all elective services will be able to move round because their interdependencies with urgent services or emergency services doesn't allow that. So will this help? Yes, I think it will, but it will take some time to embed all of these changes and get the right people in the right place. And I think there are elements that once we have these facilities available, we'll need to look at new ways of working to maximise the benefit that they might bring. But again, having the right people in place is key to that. And so this is the first step, if you like, of many steps that we'll need to do in order to deliver our tomorrow's NUH ambitions.
All right. Yeah.
Can I ask you what the biggest challenge is then with regards to recruitment? What is it, because they're not there? Is there a reason why recruitment is so challenging, or is it a number of reasons? What is it?
I think it's multifactorial, and probably there are nuances from different areas and different subspecialty of role. So there are certain types of body that are less available. They haven't been trained. And that can range from a consultant anaesthetist, which is, I think, a national shortage area, all the way through to team members such as operating theatre practitioners who are also need to be trained up and have particular skill sets. And then there are teams beyond the theatre team, if you like, so colleagues in portraying or X-ray who need to be available to a theatre team in order for them to deliver their particular kind of surgery. Perhaps not the types that we're talking about today, but in the generality of theatre work, they all have a role. So lots of different answers to lots of different questions, and you'll be aware that there's lots of talk about a workforce plan for the NHS and indeed social care, and the sooner that comes the better, because obviously even when that arrives there'll be a lag time before we've actually trained the people up that we need.
Thank you. Councillor Carr. Sorry, my apologies.
Yes. With regards to the surveys, just very briefly, I've always been the opinion consultations usually happen when a decision's been made already, but that's neither here nor there. But we're sat here saying you should have more surveys, you should have more surveys, but we've already been told that this consultation was taking place at a time when there was huge pressures on the NHS, and and actually trying to get more people to fill out a survey, to be quite honest with you, and I'll be quite frank about that. We're getting, when we talk about recruiting, of course, one of the issues, and I wouldn't expect you to comment on this, is the fact that a junior doctor, for example, when they graduate, their starting salary is 29,000. They can hop on a plane quite easily to Canada, where it's 45,000, and Australia, where it's 60,000 as a starting salary. So we shouldn't really be surprised that there's a recruitment issue in the health service. With regards to this unit, I think it's excellent. I was once very lucky to be on an elective list, and I was first on the list. So I went in before anybody else. A simple removal of a gallbladder, which should have taken an hour and a half, turned into 4.5 hours, because they find things when they go in there that they don't know about. Plus, also, after me, I was aware that there was an emergency that had to be done in that operation. So everybody else on this elective list, out of the I don't know how many were on it, but a lot of them didn't get their operation that day. It was cancelled. So anything that takes the emergency aspect out of it to deliver the operations on time when they've been promised and when you're waiting to have it, to me, is only a good thing. And wouldn't it be nice if we could do this for the whole of the NHS, but resources don't permit that at the moment. But yeah, I think this is an absolutely excellent healthcare initiative, which will only improve the outcomes for people. Thank you.
Thank you for that. I don't do gallbladder surgery anymore, but I am frequently in the position where I find things that I wasn't anticipating, and my operations take a bit longer. So I'm grateful for the appreciation of that. It also means that I have to take the building delays with some pragmatism as well, because there's an element of similarity there in terms of what they encounter. So I'd recognise that as well.
Thank you very much. Now, does anybody else have another question? No? Well, thank you for your briefing, and thank you for answering the questions from members. We are asked to consider the timescales for full implementation, but you've had some delays. So, are you all absolutely certain when you'll fully implement by the summer?
I think we're very confident that this summer the wards and the theatres will be open, and so the programme that is due to be delivered at City will have started by August, to allow a little bit of summer. I'll take that under advisement. The consequential steps, if you like, that I mentioned, as in the knock-on benefits of this, will take a little bit longer to fully implement in terms of making full use of all the capacity that's released and new ways of working that might follow.
Okay, and then also I would like to ask you to write to us by the end of July 23 to say whether the theatre is actually in being and you're using it, and whether everything you wanted to be completed is completed, and that you're fully operational as you want it to be. Obviously, you've had the slight delay. We all know delays happens in every project. The smallest project, you get delays. But would you mind updating this committee by July 23 with, as to whether the theatre is fully operational how you're working, not to mention the car park spaces, and whether it is working as you had planned.
Yes, we'll certainly send you an update by the end of July.
Right, that's lovely. Are all members happy with that? Right, good. Well, thank you very much. That was really very short and sweet, I think. Thank you very much. You can either stay, and I'm sure you probably want to go. So thank you very much indeed. We'll just stop for a minute while Noel sees our visitors out. Right, thank you. We're back again. So we're moving on now to agenda item 5, which is, again, we're welcoming the ICB representatives, Joanna and Alex. And really, Alex, I'm going to leave it to you both to introduce your item, and we'll take it from there when we hear what you have to say. All right?
Thank you very much, Chair. Hello again. Yes, I'm Director of Communications and Engagement for the Integrated Care Board. And Joanna.
Good morning, everybody. I'm Joanna Cooper. I'm Assistant Director of Strategy for the ICB.
So we're here today just to update you on the development of the system's integrated care strategy, and also start to open up a conversation around the NHS Joint Forward Plan. I'll try and explain all those terms as we go through. If we could move on to the next slide, please, Noel.
Yes. Well, yes, if we could. That would be great.
There we go. So Amanda Sullivan, the Chief Executive of the Integrated Care Board, came to speak to you about a year ago, just as we were on the cusp of implementing the Health and Care Act 2022, which established the health and care system that we're now working as part of. And that act aims to thread together the many and various parts of the health and care system that you can see here. This is the simplified version, yeah? This is a complex landscape, and the Act is really helpful in many ways of sort of simplifying and kind of streamlining things, but it does not get us away from the fact that delivery of health and care services in all parts of England and in our area is complicated, and do all the kind of parts properly mesh together, and all the wheels and all the cogs turn in quite the same direction in the way that we'd all want? Probably not. But we're on a journey to try and make that more streamlined and more integrated. But it is a journey. One of the things that Act did was the establishment of the Integrated Care Board for Nottingham and Nottinghamshire. Joanna and I are both employed by that organisation. It's a coordinating and a leadership body. It replaced the 2 CCGs for our area on the 1st of July last year. And picked up all of the duties that CCGs had, but also added in a number of other kind of duties and responsibilities as well. The Health and Care Act also established what's known as the Integrated Care Partnership. We call that the ICP, often for shorthand. That is a joint committee between the Integrated Care Board and the 2 top-tier local authorities, i.e. yourselves and the City Council. And I'm labelling that point because the Integrated Care Partnership we think of as the guiding mind for our system. It's where we bring together the NHS and the local authorities to kind of do that strategic thinking about where we want to go as a system for our population. And the first task that Integrated Care Partnership had was to create a new integrated care strategy for our system. And that's the last of the kind of 3-letter acronyms that start with integrated that I'm going to use for a short period, but there'll probably be some more. So I'm gonna hand it to Joanna in a second to sort of take us through what that integrated care strategy is, and then I'll come back at the end and pick up some other parts. So over to you, Joanna.
Thank you.
And next slide, please, Noel.
Thank you, Alex. So, as Alex said, new duty to collaborate, and we have our formed integrated care partnership. They've developed the integrated care strategy. Lots of acronyms for the system. So a lot of work has taken place from August last year, with all of the partners on that first colourful slide, as well as members of the public, to make sure that we had a comprehensive strategy for the system. This was approved by Integrated Care Partnership on the 17th of March, and is now being launched and circulating around our organisations. It's been built up from work that we have already completed. We've not started with a blank sheet of paper. We've based this on the needs of our population. We've built on existing strategies, including our health and wellbeing strategies for the city and the county, and our joint strategic needs assessment. As Alex said, the strategy sets the vision for the system. It really is our partners coming together in a way that we haven't done before, in a footprint we haven't done before, and we've created a joint strategy that's been approved by that committee and supported by all of our organisations in the system. It's our chance to unite behind a single strategic vision for Nottingham and Nottinghamshire, and our chance to make sure we can drive that significant improvement in physical, mental health and wellbeing of the population. I can tell you a bit more in a moment about some of the things we've embedded in there, and there's some really exciting opportunities. Our integrated care partnership haven't done this alone. As I said, we've built on lots of existing work. There've been a group of specialist advisors working on a weekly basis, bringing together those organisations and overseeing the development of the strategy. You might remember back in October we had an ICS Partners Assembly event. There were around 200 people from all across the system, members of the public, attending that, and we used that as an opportunity to engage people in development of the strategy. We've got lots of new engagement mechanisms as well that came in with the Health and Care Act. So we have our Citizens Intelligence Advisory Group, we have a voluntary community sector alliance, and we've made sure that those groups in particular were involved in the process of developing the strategy. This also included an initial mapping exercise, making sure that we were talking to all of our organisations about what engagement consultation they'd had with organisations over the previous months, to make sure we weren't asking members of the public the same question over and over again. They told us what they wanted, we made sure that was included in our strategy. Our partner organisations and our place-based partnerships were also part of this process of developing the strategy. And now everything's on our website, and a strategy launch plan has been implemented to make sure those key messages are being disseminated. Can I have the next slide? Thank you. So, what's it all about then, rather than me telling you how we got there? It's a shift towards prevention. From that mapping and building up from our existing strategies, we know that people in our area, Nottingham and Nottinghamshire, people are dying earlier than they should be, and they're living with illness and disability longer than they should be. We've got significant challenges with deprivation across the whole system, and the public are strongly supportive of us moving more towards an upstream preventative approach. So we've really tried to build that into our strategy. Could I have the next slide, please? Thank you. This slide just gives you a bit of a snapshot. We do have a really helpful executive summary of the strategy that's only a few pages long on the website, if that is of interest to committee members. So our vision is inclusive of the whole population. It's a holistic view of health and wellbeing, including physical, mental, social wellbeing. So our vision is that every person will enjoy their best possible health and wellbeing. On that row below with the symbols, we've aligned to the national aims for integrated care systems. We thought that would be a helpful way to ensure that all of our organisations could be supportive of that. But as well as that, we've really wanted to embed 3 principles, and these are the 3 key things really in the strategy that I'd like you to go away with. Prevention is better than cure, so just bearing in mind that kind of public view and that broad support for us to move to prevention. Equity in everything, and possibly familiar through health and wellbeing board conversations that Councillor Dr. John Doddy and Jonathan Gribbin, your Director of Public Health, have been really pivotal to making sure that we embed equity in everything that we're doing. And integration by default. So rather than integration being the exception, we should be asking ourselves, why aren't we integrating? Why aren't we working closer together? It should be the thing that we do as a matter of course. Can I have the next slide? No. Thank you. So as well as those aims and ambitions, the plan outlines how we're going to do this. So we've got some key actions in there around how we will be supporting our workforce over the coming years, how we'll be working with our people and their communities, how we're using the evidence base, whilst at the same time encouraging innovation, recognising that sometimes the evidence base takes a while to develop and we want to make sure we're on the front foot. We'll be looking at outcomes and impact to make sure we're making a difference. So we have for the system an outcomes framework that we've co-developed across the organisations, and we've been making sure that really comes to life. We have delivery vehicles already in place, so we have our place-based partnerships across the county that work with local communities. So we'll be making sure that we maximise those vehicles and the health and wellbeing boards. And our last kind of how focuses on how we'll have the right enabling infrastructure to make all of this happen. Brilliant. I think I'm handing it back to Alex with the next slide. Thank you.
Thank you, Joanna. So I hope that's a helpful kind of summary of what the strategy says. We're really eager that it doesn't sort of just, sit on a shelf somewhere and gather dust. I think we've all been in enough kind of meeting rooms where you rifle through the store cupboard or the filing cabinet that's there and you find a strategy from 10 years ago that kind of hasn't ever been implemented. So we're really keen that isn't the case. So we've invested considerable effort into making sure we've got a variety of engaging and accessible materials, particularly focused for all of our staff across health and care, but plus citizens who might kind of sort of be particularly interested in this, but mainly for staff so they can really kind of understand what this means and how they can be a part of this and make small changes in their everyday kind of working sort of lives that will help move this strategy forward. So you can see some examples here. There's a dedicated space on our integrated care system website. There's a couple of summary documents that boils it down to a really accessible level. There's a video for people who like to interact with content in that way. There's a comprehensive social media advertising plan. And we've also developed a number of case studies to really kind of bring the kind of work to life as a kind of set of examples so people can really kind of understand what this all means. So I'll just take you through 2-3 of those case studies. For example, we've got quite a sort of bank of these now to enable us to share it. So if we think about that principle of equity, which Joanna talked about, that is, of course, as colleagues will understand, different to equality. This is about being proportionate with how we invest and deploy our services so that everyone has a fair opportunity, an equal opportunity to achieve what they want to. But it doesn't mean delivering the same services to everyone. So this example here of Samantha, she had considerable kind of challenges in her life. Combination of poor mental health, homelessness, sort of being slightly disconnected from the support that was available through substance misuse. This is a citizen who would need a lot of support to kind of get to sort of even keel. And I think this is a really good example of working collectively across statutory services and the voluntary sector coming together, making sure that we're wrapping around the support that's needed to ensure that someone has access to a GP, is engaging with the services that will make a difference for them, is working with voluntary sector providers like the YMCA. And this shows a really good kind of set of results. This individual kind of hasn't been seen by one particular team since that intervention kind of came into place. And a really person-centred approach has made quite a difference there for this individual. So that's the sort of care we really want to be ongoing basis for everyone. And the next one, please, Noel. So picking up the theme around prevention, there's lots of different types of prevention, and we're having quite an interesting discussion with colleagues across both the local authorities at the moment around what we mean by prevention. For me, I think this is a great example. We know that there are considerable challenges in all of our communities and in all of our own personal household budgets with the one of the ways that can be challenged, not the only way, and I know that the root of some of these challenges are simply that people don't have enough money. But by upskilling people, giving people the right level of confidence, building that kind of social capital around healthy food and healthy eating and being able to cook for yourself has made a real difference for some people. Some really nice kind of quotes there from people around the confidence that it generates for people and the ability for people to access healthy food. It is one of the ways that we can help deliver on that challenge, but I appreciate not the only way, but a good example, I think, of preventative work. And then finally, in terms of some of the case studies, thinking about our integration by default approach. We've done a lot of work in recent years around supporting people to die really well. Everyone is going to die. That's a simple fact. So the conversation needs to be about how people can be supported to die in the way that they want to, in a really kind of joined up and coherent way. And I think it's a really impressive statistic here. You know, we've very nearly halved or reduced by 40% or so the number of people dying in an emergency in an A&E. No one wants to die in a busy A&E. You want to do that at home or in a hospice or whatever your choice is to enable that to happen. And therefore, by integrating across GPs, hospice services, and other services that work in this space, we've been able to have really good conversations with people to enable them to make the right choices around how they want to die. So that's just 2-3 examples there of kind of what the strategy really means in real life. If we could just go on to the final slide that I'll do before I hand back to Joanna. As I said, we want this strategy to be something that's live and ongoing and part of an ongoing conversation with our population. And one of the ways we're doing that is through our regular programme of our Partners Assembly. So the next one of those is on Monday, at Medicity on the Boots site in Beeston. We've got, I think, nearly 200 people registered to come along to that already. You'd be very welcome to come along as well if you want to. And it's an opportunity to hear some more about the strategy and also, in particular, the next part of the conversation, which is how we're going to deliver and implement this strategy. So I'm going to hand back to Joanna now, I think, to kind of start to open up the conversation around what that's specifically going to look like for the NHS contribution to the strategy.
Thank you, Alex. So, as Alex said, we're moving to NHS implementation of the strategy through the 2 local authorities. We have the health and wellbeing boards already in place. We've got health and wellbeing strategies and implementation plans that support those. So we are focusing solely on the NHS just for this little part. Work's underway on developing our joint forward plan. It's a 5-year plan again supporting the strategy with a deadline of the 30th of June for this first iteration. It will be something that's refreshed on an annual basis thereafter alongside the strategy. So we're still in that drafting phase. The scope has been agreed and we've agreed collectively that the joint forward plan will deliver against the NHS mandate, tackling some of the tricky issues that NHS partners are facing, as well as being that NHS contribution to delivering the integrated care strategy. It is, again, an opportunity for our system partners to galvanise, come together and create a longer term vision for NHS teams and our public. And we're working together alongside our two health and wellbeing boards in developing this plan. So there's been an initial conversation with the County Health and Wellbeing Board and sessions planned over the next couple of months. Could I have the next slide, please? So continuing on working with our local authority partners, we'd really like to invite views from committee. I'm sure you've all got lots of questions and your own thoughts, but on these areas in particular. So what NHS features, development services are most important to celebrate and strengthen? I think it's important that we recognise where we are as a health and care system, and really take the opportunity to celebrate some of those successes. Where do you think there are areas where we're making progress, where we might need to improve upon? So we've already in that last item spoke about the elective waiting lists. Are there other areas that you as a committee are cited on and would like to see reflected in these plans? And where should the most important changes in the way that care is delivered and improved over the coming years? Where are those areas? So, thank you for your time. I'll hand back over to the chair. Thank you.
Just one question. You've obviously got to monitor your progress on this and evaluate delivery. Where does the Health Scrutiny Committee fit into this?
It's a really good question, and I'm not sure we know the answer, if I'm totally honest. The Act that I mentioned is, I think, really clear and helpful on some things. It leaves constructive ambiguity, I think is the correct phrase, on some other areas. As always, we'd be keen to come and talk to the committee about whatever the committee wants to kind of have on its agendas. But it is definitely the case that we're working incredibly closely with the health and wellbeing boards as well. So we probably just want to kind of make sure that we're not doing almost the same conversation twice, because that would be inefficient for everyone. But certainly we'd be happy to come to whatever committee you want us to come to. I think Joanna, unless there's anything you want to add.
And also, when you've got something to report, you can come back to us. Yeah.
Only to add, the role of the Integrated Care Partnership is to set the strategy, and they will be having a very keen eye on how it's delivered. So they have a forward programme of work. They meet twice a year roughly, with the partners assembly meetings in between, so that they can act on citizen insights. But they will be looking at specifically the impact and how that partnership can create the right environment for success.
Right. Okay. Councillor Wilmot.
Yes, very informative, and thank you very much for the report. It is very varied and wide-ranging, and I welcome that you'll be working with our two health and wellbeing boards in developing the plan. But what I'm asking is, what processes really is it available to monitor and evaluate the delivery plan? I hope you will be constantly updating the plan and reporting back to us the outcome.
Councillor Wilmot, I've just asked that question.
Yeah. I'm going through the whole lot of it. I say I hope you'll be constantly updating the plan and reporting back to us the outcome, so we can obviously scrutinise the process. Early intervention schemes. I'm glad good that you did mention that, but it is essential that we try to stop the problems before it occurs. That's absolutely essential. So more and more and more early intervention programs must come before us, so we don't have the problems as much as we've got at the moment. Information. How are you going to keep members of the public involved so that they can comment? Obviously, you just said website and so forth. I just wondered, there are 25% of the population that aren't on the website and don't read newspapers. I just wondered how you were going to keep them informed on what you were doing. Mental health, a very, very serious issue. Can you tell me how are you going to get the information out there about mental health? Because I think as a counsellor, there's not a week goes by that I get someone with that problem asking me if I know the answers to it all, which obviously I don't. And will you be working with the social services, the council social services on that issue, because they have that problem, a serious problem also. So you have to work together to help other people. As I say, I'll look forward to seeing progress on the whole situation, and thanks very much for, as I say, for all the help you are giving and for the information. It's going to be obviously difficult to report. And do you feel that you are addressing all the problems that you have at present with this forward plan? And as I say, I'll look forward to seeing progress. Thank you.
Sorry, Chair, did you want me to
Yeah,
respond to
please
that?
do.
Thank you, Councillor Wilmot. A really comprehensive set of questions. I'll try and pick out some of those, and I'm sure Joanna will want to come in as well. So, absolutely, we will come and update to the committee in whatever way that you want. And as Joanna said, the Integrated Care Partnership, which has representatives from the County Council on it as well, will be kind of key to overseeing that alongside the Health and Wellbeing Board. Heard your plea for kind of more work on early intervention and more work around mental health. So thank you. Those are really key priorities for us as well. So that's good to kind of hear that. Do we believe it's comprehensive or kind of cover every single issue? I don't know, if I'm honest. We think it's pretty comprehensive. I'm not sure it'll ever be able to kind of touch on absolutely everything, but it's designed to be a strategy which talks to all of the key requirements for our area. But there will always be new things that come up, so that's why it's helpful that it's able to be sort of refreshed on an ongoing basis. And thank you for your reminder around, not everyone is online. I don't think I'm going to be causing a scoop against the Hucknall Dispatch, but you should see next week, I think it is in their edition, a column from our chair talking about what the strategy is, setting it out for people. So the residents of Hucknall who read the Dispatch will be able to see that without having to go online. So that's just one little example of how we're doing that. And I hope that they aren't cross with me for spoiling that exclusive that they've got. Joanna, is there anything else you wanted to pick up?
Thank you, Alex. How can I follow that? Just to add about the nature of the strategy. So we have built it up from our health and wellbeing strategies, our joint strategic needs assessment, and those documents will iterate over time to reflect the needs of the population. I think we have in this strategy covered the things that are the most important to our local people at this point in time, but we will be having that annual refresh to make sure that we are staying on top of that and reflecting the needs of the population as they change. Thank you.
Thank you. Councillor Welsh.
A couple of things. The first thing I want to ask about, and I know it won't come as any surprise to Alex, I'm going to raise this probably, is in regards to healthy eating that you talked about with regards to one of the case studies. Many moons ago, when I worked in children and young people services, and we had Sure Starts and healthy eating, we ran a parent and child programme. It ran across Nottinghamshire, and we had local chefs involved, and we set up little cooking stations in schools, and they got a little healthy recipe card with a recipe on of local things, and they cooked food together. I'm aware that some areas already do that. It was really, really positive, and it was funded through what is now the People Premium funding, and they actually went away with those ingredients, and they made it the next night at home. And it was quite good, and they did this for a number of weeks, and actually it was a really, really good way of doing it, and it encouraged parents together, and everyone could get involved. So anything like that encourages that togetherness with children, I think is something really positive. So that's my positive contribution. So I agree with what you're doing with regards to healthy eating, and I think you were only right, Alex, to acknowledge in what you were saying but it's easier said than done at the moment. In where I represent in our North South, food bank usage is through the roof. It is absolutely through the roof. Unbelievable the amount of people that are walking through that door at the moment. So my question is, with regards to the integrated, care system, with regards to how are you going to work with these people that provide the food as well? So you've not only got food banks, but I know, for example, I'm talking colloquially, but everyone will have it in all of their areas. The people that do soup kitchens, for example, churches do. We have another church, Emmanuel Church in Bestwood, just outside of my area, that every does a free takeaway service or a free meal once a week. Queues out the door. It's really healthy food, but it comes at a cost. Is there a mapping exercise going on when you're talking about healthy eating and where that is, and where those areas are being most affected, and how are you going to work with those people that are trying to keep communities healthy, relying on voluntary contributions to keep our communities healthy, because they need the support, because they're delivering it on the front line. They are the ones that are providing fruit and vegetables to a lot of our children that are living in our communities, because people can't afford them at the moment. And why that is, I'm not going to debate that today. The reality is that is happening. Whatever your political persuasion is, that is happening, and for whatever reason. So what are we doing with regards to that, and how is that being? Because that's about equity. There's nothing more important than the children having the best possible start ever and having healthy food. That to me is really, really important. So that's my first kind of point and question. My second point relates to when you talked about hospices and dignity in dying. I'm not going to go into too much detail, but we as a family have had a really unfortunate situation. Really, we've lost two friends, and one received exceptional care in the hospice. Now, it's my first involvement really with knowing what goes on in a hospice, and it's unbelievable what they do for the care of that person at their end of life. And like I said, I've never known it before, and I've never come across it. It is absolutely exceptional. And I think in the absolute ideal world, everybody should have what that person should have that. Absolutely everybody. The fact that his mates was be able to go in and have a drink with him and watch the football, all of those things, absolutely, how it should be. But it doesn't happen for everyone. And there's some concerns that have been raised to me by others that there's a capacity issue in our hospices at the moment. And that even if you want that, you can't have it as such because of the capacity. And I know you talked about the dignity of dying, of not dying in the emergency room, and that is, you're right, we have to avoid that at all costs. But I think there's some real important work that needs to be done for us in Nottinghamshire to ensure those people that are, and those families do get that opportunity to, if they wish to do so, be in the hospice, to have that level of care where they can involve their family and friends. It's especially if there are children involved as well, it's very important. So I just wanted to, one, express how fantastic this hospice is, but just to say, how do we increase the capacity, and how do we work with that? How do we ensure that with the work that you're doing?
Thank you, Alex. Would you like to come back to that?
Thank you, Councillor Welsh, as always, bringing a real personal connection to the issues, but broadening it into a strategic point as well. So I'm grateful for that. I'll answer your first question around the kind of access to healthy food and sort of food banks and soup kitchens and so on, because you're absolutely right. I'll leap over the kind of sort of reasons why that increase has happened, but it has happened. You're absolutely right. One of the ways that we're working, particularly with food banks, is through our voluntary community and social enterprise sector alliance. So we have set up this alliance for our area to draw together lots of the groups that you touch on that are contributing into the health and care space. So it has representatives from our local kind of neighbourhoods voluntary sector groups, some of the umbrella organisations that sort of coordinate some of the smaller groups, And then in recent months, we've invited onto it representatives from some of the larger voluntary and charitable organisations who kind of operate on a sort of regional basis. So we've got representatives from, Alzheimer's Society, Age UK, all the ones you kind of might imagine. I'm really pleased that we've also got a representative on that alliance for our area from the Trussell Trust, who are doing exactly what you described, I think, in a fantastic, compassionate way. And by connecting with them, we're able to then have the conversations exactly as you've described. The Trussell Trust's ambition now is actually to work towards a world where there are no food banks, which is quite a strategic change for them. And I think that's quite an exciting space for us to step into with them, because they've got incredible reach and connectivity into their community. So how we can work with them to kind of make that change is going to be really important. We've noted in recent kind of months that probably our connection into the faith sector that are doing similar sort of work perhaps isn't quite so strong. So there's more for us to do there. And thank you for a couple of reminders of some of the really good groups that are doing that work, because I think we can take that forward. So thank you. I'm going to chuck a bit of a hospital pass, I think, to Joanna, because I'm not sure I know the details of how we're working with the hospices, and I don't know if you do, Joanna. But if not, we can take that away as a area that I think you're supportive of, which is kind of one of the questions. But we need to understand, do we have the right capacity? Because it's all right for people to express their desires, but if we can't then fulfil it, then that's perhaps less helpful. Joanna, I don't know if there's anything you want to add on.
No, sorry. But it is something that we can definitely take away. And sorry for your loss.
Okay. Vice Chairman.
Thank you. Just a really quick question about the Partners Assembly. Is there any chance that that's available online for people who can't attend? Just because it's middle of the day on a Monday. And if it isn't available online, would there be any notes or any information that can be passed back to us so that we've got them for future? Just 10 till 1 on a Monday is not very helpful for some people who work. Thank you.
Thank you, Councillor Reddy, and I take your point. We're trying to kind of sort of rotate it both geographically and timing wise. So the next one will probably be in sort of September, October, and will probably be kind of later in the day into the evening. We will undoubtedly get criticism from people then of, why are you running it in the evening? Why can't it be during the working day? But it's a balance, isn't it? It's not going to be kind of streamed online because it's not going to be, but we will do kind of a report out of it, absolutely, for kind of circulation and for use. And I'll be really grateful for you to take an interest in that and share that with your networks as well.
Thank you, Councillor Fall.
Just on that one, Councillor Reddy, I think one or two of us have signed up for that assembly. So if there's anything you'd like us to ask or report back on, then let us know, and we'll be happy to do that, because I think a couple of us can make it. But you're right, it isn't the best time of it, isn't it? Okay, that's great. Okay, I mean, I suppose the overall kind of impression that I got here is the question that arises when it says, where does social care sit in all this? And just to give this could cover a number of things. And one is, there's been an awful lot of emphasis on getting people, particularly older people, out of hospital into social care. But it's the other way around too, isn't it? How do you prevent those older people, in particular those kind of later life with life-threatening illnesses, from going into hospital? Perhaps a little bit more about that would be good. The other one is something I feel very passionate about. I know Councillor Welsh does as well. A lot of us do. This is around mental health. If you want to tackle early intervention, you need to tackle mental health, and particularly young people's. I'm not suggesting older people don't have poor mental health, but particularly for younger people. There is a pandemic of mental health difficulty in this country, much worsened by the pandemic. And I think that's something that, if you really kind of want to address in terms of prevention, I think it's something that we should do. Just to give you one example, I just wondered to what extent, because this, as you say, this was very health service focused. I understand that kind of today here, but do you look beyond those boundaries enough? Because one of the suggestions I was going to make, and I've banged on about this quite a lot, is our youth service, which has been supported by both Labour and Tory administrations in this council, is brilliant in terms of seeing mental health issues arise early on. Now, they've struggled for funding because it's a non-statutory service, but they still do a brilliant job in this country. It's a really good kind of youth service and continues to be so. They could really be at the front line in terms of kind of watching out for that kind of early intervention, preventative work around mental health. I just wonder if that could be part of your part of your kind of portfolios, kind of so to speak. I think the visions that you've described in terms of early prevention, equity, and integration is brilliant. I've yet to see how that's going to kind of pan out and what impact that is really going to have. I went to one of the early integrated care partnership board, I can't remember the meetings here, a while back now, and there's some wonderful words and a lot of really good intent, but I could see very little kind of, I had no idea what impact that was going to have. And I don't want to sit in any more rooms and hear wonderful words. I want to sit in rooms and hear real things happen to real people, and I'm not seeing that to be honest with you, at the moment, as a result of this kind of integrated work. And just one last thing as well is, and I realise I should have probably raised this issue. I asked you about consultation under the previous item. I wonder, could we see what your kind of, if you like, ICS approaches to consultation, and how you're going to get more than 22 people for a specific thing and a few thousand people for another thing. And I think it's a lesson we could all learn, because, as I say, it happens here too, doesn't it? It's very difficult to get decent numbers engaging in in terms of a consultation. And if this is really going to mean something, and you're really going to have some kind of proper input from the public, then we've got to find a better way of doing it. And that isn't meant to be part of political. I'll go at you in particular. I mean, as public institutions, we need to really tackle it and find a better way of doing it. Thank you.
Thank you, Alex. Joanna?
Yeah, when I pick up that last point, I'm more than happy to circulate our strategy of how we, our strategy and our kind of policy of how we involve our citizens. Very happy to do that. And I will just say that very briefly, whilst we were developing this strategy, we did do quite extensive work to kind of involve our population. In fact, it's been recognised by the Department for Health and Social Care as one of the best in the country. I feel like we've probably acquitted ourselves better on that than maybe what you've seen earlier today. But yeah, we can certainly circulate the approach. Joanne, do you want to pick up some of the other topics?
Thank you, Alex. Thank you for your questions, Councillor Fall. Going back to the start, where does social care sit in this? So we've worked with our social care colleagues from children, adults, older adults in the development of the strategy. So Melanie Williams is part of the Integrated Care Partnership, and Catherine Underwood for the city. So we've got a real balance of those children's, adults' needs. In the strategy itself, we've got a focus on children and young people and making sure that our children and young people have the best start possible. And there's a range of actions in there that we've committed to as partners, and information on how we'll monitor that. So we're looking to turn the needle on some key indicators around children and young people in particular, and around older adults. We've picked out those two specific cohorts of the population as having the most pressing needs that we need to address collectively, and where we can make the most impact for local people. Absolutely agree, mental health needs are really key to address, and I think a lot of the issues that we've picked up on this in a few different questions, haven't we, that you're seeing in your surgeries are because we haven't been taking that early intervention preventative approach. We have started to implement things like social prescribers, who are working more closely with local people, making those local connections and making sure people have the support they need and start to develop their support networks in the local community. It's that sort of initiative that we want to make the best use of, maximise within the strategy. I think that was the last question around impact, seeing there's real things happening to real people. Absolutely. We have our system outcomes framework that we've collectively signed up to. There are lots of indicators in there that will be considered by Integrated Care Partnership, the Integrated Care Board, our two authorities and NHS partners, with the idea that if we're not monitoring something, it's probably not happening. So it's just to try and shine a spotlight on some of those really important things for the population, so that we can make sure we are demonstrating that impact, as well as that more tangible, real stories. So the case studies that Alex shared, we've got a programme of work to make sure we are engaging with all of our partner organisations to really highlight some of the good things that are happening and use that as an opportunity to upscale and spread some of those really good initiatives that may be happening in one area of the county, but actually it'd be fantastic if it was happening everywhere. So lots of opportunities through the strategy. Thank you.
Councillor Carr.
Yes, thank you. Just a couple of things, really. Well, one thing, because it's related. Where does this full plan fit in with the services that this council and Nottingham City Council provide? As there at the moment is a substantial problem with not having enough social workers, and there's a problem with not having enough child psychology assessors. I can tell you now, I have a lady who I had to do an urgent referral to 5 weeks ago to our MASH team, and I still haven't heard anything back from them. It's not because they're not doing the job properly, it's because there's not enough of them and they're overworked. And I have a case where a resident of mine has been told that her autistic son cannot be assessed for his needs for 5 months because there is a shortage of child psychology assessors. How is this joint forward plan going to address that situation?
Who's going to answer that?
Thank you, Councillor Carr. In the development of the joint forward plan, as well as the strategy, we've got a commitment to supporting our workforce, looking across the workforce collectively for health and care, recognising that quite a lot of people actually move between health and care services. There are deficits in certain working groups. I think we talked about that earlier in relation to elective care services. We are looking at exploring different models of making the best use of skills within teams. We're looking at things like a staff passport that enables people to move across organisations and work in different areas geographically and speciality wise without necessarily changing their employment terms and conditions. Also looking at things like health and wellbeing hubs to support our existing workforce to stay in the roles that they have, so we don't have further problems. At the other end of the scale, our people and culture strategy also looks at making sure we're developing that pipeline of people coming into the roles, those in particular where we do have staffing shortages. So working with our local colleges, schools, developing that pipeline of children and young people who actually want to take careers in health and care, so that in future years we do have that workforce available. But that's there's a few things today, longer term vision to address.
Thank you, Joanne. Anybody else got any more questions? No? Well, thank you, Joanna and Alex, for coming in and explaining. Clearly, this is a moving operation, as it were. And I would like to ask that you keep it in touch with your progress. And when you feel you have really something to come back here to tell us, please tell Noel and he'll fit it in. And if you feel also that this committee can help you anyway, then let us know. We'll slot that in and we'll have a look at whatever you'd like us to look at. It's all new. Everybody's learning. And I appreciate that. And if we can be of any help, additional help, then please let us know and we'll take it on from there. Is that all right, Alex? Okay, so thank you very much, Timo. Before we finish, members, I'm sure you want to go, Alex, so please feel free to go. We'll see you before too long, I'm sure. Thank you. In March of this year, Vice Chairman and myself made a visit to the emergency department at Queen's, and Bethan is going to give us a report of what we saw, what we did. It was a very interesting visit, but I'm going to leave it to Bethan to fill us in, and then I've got some odd bits to say, I think. So, go ahead, Bethan, when you're ready.
So, it was a really, really interesting visit, and it was on 5:30 on a Monday night. So it wasn't overly busy, it wasn't overly quiet. It was just a normal Monday night. First, I just want to say thank you to the staff that took the time out to talk to us, because they did give us a lot of time, a lot of information, and I tried to make it as concise as possible as to the main things we found when we were there. When we got there, they took us aside and briefly described how the system worked. And the way they described it to us was in three types of sections. So you had your trauma, so like your road traffic accidents, that was one bit. Your ambulance, people coming off the ambulance, that was another bit. And then your urgent care with your GPs, that was another bit. So if I take it in three separate sections, one of the main things we found from the access to GPs, and I know 5:30 on a Monday evening, most GPs probably aren't open, but 30% of people weren't even registered with the GP, and I found that statistic quite high. And I think that was something, and I think that's probably more of a Nottingham City based issue rather than a county wide. But I thought that was something that it was a very high statistic, wasn't it, to think of it in that way. And the waiting times, they were quite long, weren't they, in that area? But they were being seen and triaged as appropriate, I think.
Yes. and they're prepared to go and wait, because if there are staff missing and the consultants have got to stand in, people know they can see a consultant without any ado. So if they've got a problem, they go in, and hopefully, if there's a strike or something and the consultants are standing in, then they get to see a consultant, which is an added bonus to them. But go ahead, Bethan. Yes.
Yeah, it was one of the weird things that the strikes had meant more people had gone because they thought they'd see a consultant as opposed to being triaged. It's all very anecdotal, wasn't it, that bit?
Yeah.
The second point, and I think this is one of the major things that Anthony May talked about when he was here, was the flow. When people coming off the ambulances, there was nobody waiting in corridors, but what they had done is they had a section where it was normally split into 3 lots of 10 beds. But because of the number of patients there, it was 3 lots of 15 beds. So you had your bays, and then people were in the middle of this huge room. And the main issue with that was that out of the 45 people who were there, 40 of them needed beds, but there was nowhere for them to go into the hospital for the beds. So the backup on A&E, the people coming off the ambulance were going into these bays, but then there was nowhere for them to go after. And they said when we were there that out of those 40 people who needed beds, 240 people across any age could go home. So it was a definite issue of flow out of the hospital, because what I took away from the visit more than anything was A&E as a system does work if you've got the flow out of the other end of it. So people get seen, people get triaged, people get treated. It was more the flow out of the hospital. So of the 45 people who were waiting there, 40 of them needed to go on to wards, and they just couldn't. So that's where you then got the backup when it got busier. And I think that was the second major point that I took away from it, was that there was 15 people in bays where there should have been 10, and secondly, there was nowhere for them to go when they needed to just go onto a ward. And I think that's something that we need to look at. And I know it's a much bigger system than there wasn't a bed available, and I think it's something that as a committee we need to look at a system-wide aspect. So not just the social care. When Anthony comes, he'll talk about the medication, not getting people's medications, they can't leave. And I think it's a big process, but the main things I took away from the visit were 30% of GPs, people not having a GP, which I think is quite a high number, which has meant that side of it was very busy. The flow, so 40 people needed to go into the wards, but there weren't the beds available for them to go into the wards. But as a whole, A&E did work if you take it out of context, if that makes sense. So people were triaged, people were seen, people were... But as a system as a whole, there were issues in the system as a whole. And I think that was my major take off the visit. I mean, we were only there for an hour and a half, so you don't see huge numbers. And like I said, it was a Monday evening at 5:30, so you wouldn't expect it to be overly busy anyway. But there was already people waiting that had been there for quite a long time. And I think one of the major things about being not in a bay was there were just beds in the middle of the room, so you had people with quite a lot of pain, with no privacy. And I think that was the major thing, the flow out of A&E into the hospital. And I think that's something as a committee we should look at in a bigger picture, with adult social care, with hospitals, with everything. And I don't know if it's something that we all think we should do moving forward. Yeah.
And it's the prescriptions, collecting the prescriptions, because they won't let them go without prescriptions. For some reason, it takes such a long time.
And then the other thing to add was that the consultants have actually invited us to take part in one of their meetings. So we saw the operational side, people moving around, but actually the decision making, they said that we can join them for one of those meetings. That'd be quite interesting to see how, why, and what they do and why they do it. So I think we'll take them up on that offer. And they have said if anyone else wants to go and visit, they're more than welcome to. But if anyone's got any questions, we can try and answer them.
Michelle.
Yeah, it is a point more than a question, a few points. My own experience of A&E is very different from what you had. My dad was one of those people that was left in the middle of a corridor for hours and hours on, someone that is terminally ill. It was appalling, utterly appalling how my dad was treated in that A&E department. And it's not the first time he's been treated that way. It was disgusting, utterly disgusting. Then you talk about 15 people in a bay with 10 people. That's someone's dad, that's someone's mum, that's someone's auntie, that's someone's sister that's been shoved in a corner like my dad was. No one allowed to be at his side when he's confused, doesn't even know where he was. In a corridor surrounded with people, no dignity to even go to the toilet, has to have... It was absolutely outrageous. He came off the ambulance and was left in a corridor. The ambulance drivers can't go anywhere until they've signed the paperwork off. There was 24, I counted them, trolleys, all of them with elderly people on, all in this corridor with 2 paramedics at the side of them in A&E at QMC. So I would suggest, if we want to get a real idea of what happens in A&E, we talk to the people that are sitting in that room. We talk to those people. How long have you been here? Have you been here before? What was the aftercare like when you went last time? And we go on a Saturday night or even a Saturday day, and you walk through those corridors, because I can tell you something now. I couldn't believe that our country has come to this. That we leave old people in corridors when they are ill in our emergency department here in Nottingham. That's not getting political, that's the reality of it. I was utterly shocked. So I think it's more, to be honest. I don't believe the flow does work. It might have worked on that Monday night at 5:30.
No, the flow wasn't working, that's
but,
what I'm saying.
Yeah, it doesn't. Not only does the flow not work, the ambulance drivers bringing them in doesn't work. Because you've already got 15 people in that bed, and you go on a Saturday night and it's 25, and they've got no room to put anybody. And I'm going to finish by just saying this as another example. 95-year-old man served in the RAF on a trolley for 24 hours in a corridor with not even had to find a blanket for him. So my opinion on A&E is very different to yours, and it's the truth. It was David Ellis. I'm not having a go at you. I'm not having a go at anyone. I'm just... I know, but I'm just saying the point is when you're talking about the 15 and 20 people, I think it's an utter disgrace. And I think it's going to take more than health scrutiny looking into it. It needs some wholesale changes from a lot further up or up than us, because I don't think we have the capacity to make the changes that are needed in our hospitals.
Just to come back to that, I just want to say I'm really sorry for the things that you have experienced. When we went there and what we saw, that was what we saw on the night when we went. And there is an issue with flow, and I absolutely agree with you. People shouldn't be in corridors, but when we went, we didn't see that, did we? So we can only report on what we saw on the night when we were there.
If I can just mention one or two things, we were asked not to go into the emergency department alone. We were asked to have somebody escorting us around. We had 2 consultants escorting us around. As Vice Chairman have said, it is as we saw it. I personally would have preferred to have gone on a Friday night or a Saturday night when I think it would be busy, but the Chief Executive asked us to go on the Monday night, so we did. Now, further to this, I arrived at Queen's at the same time as my grandson, and my daughter took him into Queen's. She was actually there and took him into Queen's. They had a whole different experience from the experience we'd seen in the adult care. He went in at 4:15. At 10 o'clock, I was still there because the Vice Chairman had gone home. I stayed because my daughter was there. And at 10 o'clock, they decided to give him some painkillers. So he'd actually been hanging around for that time. They didn't know whether he'd got an appendicitis or not. So they prepared him for an operation the following morning. They stayed overnight. I went home. The following morning, my daughter rang to say they're going to see whether to give him an operation or not. In the event, they scanned him, and they didn't. So at 2 o'clock in the afternoon, they arrived home. Now, apart from anything else, they hadn't had anything to eat or drink, except before I left at midnight, I took my daughter down to the Costa place and said, you've got to have something to take back. So my experience immediately after my visit to Queen's was totally different. And I stood there and I thought, how can this be so different? But I can assure you a report has gone into Queen's, for which they appreciate, and they're looking at it. But all I can sum it up at is the visit we had was very, very good. My own personal experience within half an hour after the visit finishing, was totally different. The Chief Exec is perfectly aware of it. He's grateful for the points I've raised, and they're going to look at the whole thing. We were actually sent to the child assessment unit, way up on a floor, well away from ED, and there were no doctors. And I said, where are all the doctors? They're all down in ED. So I said, well, what are we doing up here? Why have we been sent up here if there's no doctors? So then, of course, he was sent back the next morning downstairs again. So there are problems, they're aware of them. And as Michelle has already alluded to, it's not only with the senior people, it's with the children as well. And they've got to get it right, and they know that. But the coincidence of the two things was quite something. So thank you for that. Yes, Sarah.
Yes, thank you for that. Just to give councillors some insight from a Health Watch perspective. So like yourselves, we get invited to go into ED, and we also do quite informal research, should I say, in terms of people's experiences and understanding the experiences of ED, both adults and children. And then there's obviously 2 separate parts to ED. There's the acute, and then there's the sort of walking wounded, if you like. So Health Watch has been working and supporting NUH to think about some of the issues, things like food availability in the waiting area. There's a whole list of things that need to be addressed. And at this point, they are redesigning the whole of the ED floor. So there will be changes made, which will bring in some of the ideas that we've put forward to them. And they are looking very much at that environment and making it as comfortable for people, as safe as possible for people, because part of the stress that happens within an ED department is exactly that, where you're there for several hours, you've not eaten, you can't charge your phone's died, you can't let anybody know where you are. You know, and there's a whole raft of different things going on around you that you don't understand. So why are people going in front of you when you were there before them? You know, believe me, I've spent too many times in ED myself to sort of understand that. So we work very closely with them, and one of the key issues about those beds that you mentioned was to do with the way that in Nottingham at QMC, different to any other hospital from what we can understand, is that they offload ambulances straight away into the hospital. Whereas if you looked at Leicester, for instance, and Leicester Royal Infirmary, there they have people waiting in ambulances for hours. So there is a real conscious decision to move people out of ambulances and into the hospital. I guess the rationale for that is they're in the hospital setting. If anything changed, they're closer to the things that need to be done. But it doesn't take away from the fact that the flow is the major issue. And I think, you know, on different days and at different times, you will see different pressures within the ED department that we've witnessed as Health Watch. We've witnessed all of them at different times. So we've been able to feed in the patient experience of that and the impact that has on people. But that issue, we were told exactly, there was 400 people at one point when we were there that could have left the hospital but couldn't for different and varying reasons. So I absolutely support the idea of having a system-wide approach to look at that at QMC. But I think we shouldn't forget the experience of Sherwood Forest Hospitals Trust as well, where they've recognised some of the issues around social care and being able to discharge patients in that way. And they've been looking at how to support social care in order that more service could be developed. So I think there's something there for us around understanding the experience of both ED departments in our area and understanding the unique pressures that are with Nottingham and QMC because of some of the issues that we've got around demographics. You mentioned about the number of people not registered with a GP. That's down to a lot of a very large refugee population, which then impacts on the way people don't understand our system, so go straight to A&E. And they do know that they're one of the busiest EDs in the country and still don't understand, because people can't really get to the bottom of why people are turning up at ED, even though we all know, try your doctor, 111, go to your pharmacist, all of those things. So I'd be interested to understand the experience of Sherwood Forest and what they can learn, because one of the key things we're pressing at Health Watch is getting the hospitals to talk to each other. They're in a provider collaborative together, and it would be helpful if they could actually learn lessons from each other and start to replicate best practice. So I just
Thank you
wanted
for
to
that,
give you
sir.
that
Yeah,
perspective.
thank you for that. I think what I took away from both the visit, my own personal experience following it, is that Queen's Medical have at last recognised they do have problems, and they are listening, and they are trying to alter, and that it's like turning a ship down round in the middle of the Atlantic. It's not something that can happen overnight. But for me, the very fact that they have recognised that there are problems and they are trying to address them, be it going to take some time, I think is something that this committee should actually take note of, and we'll see what happens. But it's all interesting to hear everybody's personal experience. Councillor Adams,
Thank you.
you've
Yeah,
been extremely quiet this
I
morning.
know. I'm sorry about that. It's
I
completely
think
out
it
of
was too
character,
many
isn't it?
coronation parties.
Yes, well, quite possibly. It's been quite a busy few weeks as well, hasn't it? But yeah, too right. I just want to say, I think you're exactly right. I think, Michelle's experience and your experience with the child at A&E independently and Bethan's experience, I think that's it. I think there's so many different views of how things operate in there and so many different perspectives that collating those and getting to look at what those exit strategies are for people once they're entering, and whether we can look at what holes are there, what problems are coming, where can we get that feedback from, how can we gain that understanding, and try and get to the root of what that is in here. I think is the key, because no matter how you look at it, your point about flow, whether it's Michelle's experience, yours experience, or Sue's, is all based on that problem. The problem is you can't get them out quick enough at the speed they come in.
and as a result, you end up with backup, whether that be 15 and a 10 or, you know, I know I've got experience in my own family that one of my family members was stuck in A&E when they should have been transferred to a separate ward due to a very early case of COVID, and instead they were stuck on A&E and went through all the trauma, I should say, of being in an A&E department ward, if you like. You know, being in A&E itself is not a joy for anybody witnessing the kind of things that come in and out. So if there are people in there that just need to know that person was quite traumatized as a result of just physically being in that location and witnessing all those different types of things. So if the flow can be improved and the speed does get better and those issues, whatever they are, then those people particularly who were stuck in A&E can get out and be in the departments they need, not have to go through that trauma. And also, as Michelle pointed out with her father, which sounds like an awful situation to have happened. Again, with that, you know, again, that's getting that flow moving is what's gonna solve those problems.
I think at this point, if any member of this committee would like to make a visit to ED, I'm sure they would be more than happy to arrange a meeting through Noel for two people, say, to go and have a look. It's worth it because when you're speaking from here, you're speaking from something you haven't seen unless you've been in as a patient.
No, sorry, can I ask, is there a report, do they create a report that shows what these blockages are? What this is that they're talking about, the flow that you mentioned?
They have a chart up on the wall.
So they know what's causing a blockage effectively.
No, they say it's a multitude of things.
There was a database. When we went back in to speak, there was a database, and he basically showed us that there was no room on the wards, but there was room on the surgical wards, because obviously they keep a certain number of them free for people who need emergency surgery to have the treatment after. But the actual generic wards, they had no room on.
I just wonder if that data is the thing that we should be interrogating. What are those specific? Does that? Because I know before when we've asked for certain things, they don't exist, or they need to go away and find it. And I just wondered can we get that data?
Well, this all needs to come into our forward plan of what we feel we need to look at. But if you feel that you want to make a visit, you want to have a first. Yeah.
Because I could go there and see what you saw.
Yeah.
But I don't know if we're getting that was the data. We knew what it was.
No, I think what it does, it makes you really appreciate that there is a problem there. You know, but you've obviously experienced it. Councillor Fole.
Just wanted to say, but doesn't this very strongly suggest again that it's the early intervention that's key? We want people not to go to ED in the first place, don't we? And I honestly, I thought that response was weak. I did when we were asking about early intervention. I don't feel I'm really not convinced that they're actually really committed to it in a way they need to be if there's going to be a substantial shift. If they talk about kind of having enabling infrastructure in place, don't they? Enabling infrastructure for what? You know, it needs to be enabling infrastructure to stop people getting ill in the first place and stop having to go to ED, doesn't it? And I don't think, and you're talking about the changes need to be made and how you feel that actually it is moving forward, which is great. But we need a massive cultural shift to make that happen across the whole organisation. And I'm not seeing that in terms of the kind of thing that we're hearing here. Perhaps it's just me being silly.
Councillor Martin, I think you had your hand up, did you? Yeah.
Yeah, a while back. I think there's a couple of things. One is there's a recognised pathway for discharge to assess, and I'm sure, correct me if I'm wrong, but I'm sure that adult health and social care have been given a pot of about £5 million to employ extra discharge to assess social workers. But it's also about occupational therapists as well, because when they're in the wards, they need to have a plan and an exit route strategy. And at King's Mill, what they did was, because of the pandemic and because during the pandemic we stopped doing elective surgeries for obvious reasons, and all sorts of other extra essential surgeries and stuff like that. And then, of course, because they've all come back online now, there's a backlog of people in the hospital. So ordinarily, where the patient level would trough in April and peak in December or January, it's remained constant last year. So actually at King's Mill, what they did was they took on a nursing home, and they're moving patients into the nursing home and caring for them in there and unblocking the wards, and that's what they did at King's Mill.
The other thing is, so when somebody's been in and had elective surgery, they have to have what's called a start package once they're released. So they have to have the pharmacy in place, and they have to have the occupational therapist has to visit their home and make sure that it's suitable for them to live in, and that is a process which inhibits the release of people quickly. So then when they get home, they have a 6 week period where they have the 4 carers and the district nurse come on a diminishing scale over 6 weeks, and that at the end of that 6 week period, it's then decided by the district nurse and the carers as to whether that person needs to continue with that level of care or not, and whether they can afford it or not. So it's quite a slow process, and it's all there. But obviously, the pandemic exacerbated the pressure on the NHS massively, and that's what the problem's been. So the government's recognised that, but it's a latent effect. So they've only just been given that money, and they've only just been given that money, and so they're only just trying to employ extra discharge to assess nurses and social workers and occupational therapists as a result of the tidal wave that's receding from what happened. My experience over the last couple of years at King's Mills A&E is much different to that you've experienced at Queen's. So at King's Mill particularly, they are very clued up, and they have primary care unit, and it's also about the density of population in respect of the particular ED department. But of course, as well, Queen's is going to have a large ethnic minority come in that aren't registered at doctors' practices, aren't aware of 111, aren't aware of all sorts of stuff like that. So in the periphery of Queen's, you're going to get that difference completely to King's Mill, because everybody, basically the larger majority of people going to King's Mill are indigenous population, I'm going to say. So and they also cope with Newark and Sherwood as well. So they have that crossover of population, but it's not in the same density as Queen's, And I think that may Sarah probably could tell us some of that, but I think that would be part of the problem, because the indigenous populations are different at each ED department. But my experience at King's Mill is that they've got their own primary care unit in there. So if people can't get to a doctor's practice, or they can't get to 111, you can go in there. The time limits are still longer, but they're not as long as waiting to see your own doctor. So they are sorting it, and I think it's all about funding and about demographics. The difference between the two ED departments would definitely be that, But my experience of King's Mill particularly has been very good. That's all I can
Well,
say.
that's good to hear. That's really good to hear. And I think sometimes that's something we need to be looking at, King's Mill. However, what we've taken from this is, to me, Queens are listening and Queens are trying, but they're turning a massive tank around, and it's going to take a long time. And I think we have to feed back to them anything we hear in the way of experiences which are not right, and we have to assist them in anything they would like help with, that we can help bring better improvement to Queen's Medical. I mean, that's as I look at it. So, moving on, just to agree the work programme, I'm just going to ask, and Noel is going to be caught off guard because I haven't mentioned it to him. Sheffield, Noel.
Sheffield?
Because we have a Bassett Law member here.
Right.
Just a brief, because I didn't warn you.
Yes. No, it's okay. It's something that I actually circulated to Health Scrutiny Committee members and to Bassett Law District Council members as well, about changes that are taking place in Bassett Law in respect of oncology services, which are delivered and governed by it's a different footprint to most of the other services, in that it involves South Yorkshire, North East Derbyshire, and Bassetlaw. So there's a different uh, geographic footprint for that. The changes are being looked at under joint arrangements with the other authorities up in that geographic entity. There is a meeting, a formal meeting, to discuss whether or not to go to full consultation on the changes that have been in place for quite some time. This is a question of bringing these to um, uh, on a formal setting. Uh, a meeting scheduled for next week. I have been looking this morning on the Sheffield City Council website and can't find the agenda for it. So I will have to go back and make some phone calls this afternoon to see exactly what's going on. But that meeting's looking to take place next week.
Thank you, Noel. The only reason I sprang that on, Noel, I'm sorry, is because I don't want members to find out something's been happening in the background and you haven't been made aware of it. I think it's important that you do. They actually wanted Bethan and I to go up to Sheffield for a meeting at something like 10 o'clock in the morning, held at the City Council Hall, no parking, nothing. And I have said, if they really have got something to tell us, they need to come down here where we've got parking, where we've got a committee who can listen to everything, and not as going up to the City Hall where we've got to leave here before 6 in the morning to get there. We get there, there's no parking. I was always told that the Health Scrutiny Committee, if they want somebody, they come here, and that's what I've basically asked for. And then it could be incorporated so that everybody can hear, because we've got Bassetlaw members and they may want to come and listen, not just people on this committee but others. So this is a conversation for us to have straight after this meeting, but just wanted to make you all aware of it. So moving on, members, June the 20th, the next meeting. The longest day nearly.
Hopefully not.
We're going to look at the progress on tomorrow's NUH initiative. We're looking at the enhanced service provision at Newark Hospital, and we're having a bit of problem with diabetes, which they should have been here today. They didn't get their work together, so Noel had to postpone them. Whether we get them back in June, I don't know, Noel.
I would suggest not in June, given the two substantive items that are on there.
So,
I would suggest
so that our meetings don't last long. Yeah, too
July.
long. And we have got quality reports coming in, and anybody who would offer to Noel to look at one of the quality reports from Sherwood Forest Hospitals, City Hospitals, the ambulance service. It's not a big job. It's not an onerous job. They just want a short paragraph of what you feel about it, but you just have to look through it. Anybody who would offer to look at those, if not, I think Noel might be on the emails asking somebody to come forward. It isn't an onerous job, it's just a job to look at, make some comment and see how they've improved or not. Okay, and with that, I will thank all members, all officers, all visitors, and say thank you very much indeed.
If we can stop the broadcast.